Hello everyone and welcome to the last BIOS research seminar of the calendar year. It's my great pleasure to welcome Dr. Greg Pike, who's a research fellow at the BIOS Centre and director of the Adelaide Centre for Bioethics and Culture in South Australia. His background is in neurobiology, but he's been working since 1998 in bioethics and has a particular interest in its relationship with public policy. So without further ado, Greg, I'll hand the mic over to you.
Terrific. Thanks, Helen. Perhaps let's kick off by just giving a little background as to why this is the subject. This is one of those things which I remember hearing about back probably in the late 80s, I think, and just accepted it as one of those subsets of abortion. But there's certainly more to it, and it's not only more to it in terms of what the ethical issues are, but also in terms of how the business of selective feticide is being undertaken, what the circumstances are, what the justifications are that are being used by practitioners. And I think probably for various reasons, I'll try and come to a bit later on, why I think it's taken the kind of trajectory that it has. So this is mainly a bit of a review of feticide in multiple pregnancies, and it's pretty much evidence-based. So I'll try not to go on too much about numbers and stats, but some of them are important for us to understand how this whole business works. So, what are we doing? There we go. So there are a couple of different contexts here. The first one that I remember hearing about was the one generally termed selective termination, selective reduction, selective abortion, and so on. And that's when there's a multiple pregnancy and one or more of the fetuses is diagnosed with an anomaly and selectively terminated. That's really the very earliest stages of selective feticide. But the one I want to really focus on is this one called multifetal pregnancy reduction. So this is somewhat different in that it's the termination of one or more fetuses, but not on the grounds of diagnosed disability, but to reduce the risks associated with a multiple pregnancy. The important point here also, I think, is that it's really an arbitrary selection as to which fetus or fetuses go. So it's not really targeting anyone in particular, except for this third sort of category where the two are somewhat combined so that a diagnosis of anomaly can precede MFPR. And this is partly to avoid terminating healthy fetuses and leaving ones with an anomaly. So if you do a multifetal pregnancy reduction, say you start with triplets and you want to reduce down to a singleton, then if by chance you terminate two healthy fetuses, the woman is then left with a fetus with an anomaly. That is seen as a worse set of circumstances than if you were to be able to diagnose and selectively terminate before doing some further fetal reduction to get the numbers down. So you can probably pick up straight away from the way that I'm talking, this is a deeply utilitarian kind of process. It's a few things first about multiple pregnancies. You can see up in the right-hand corner there the Dion identical quintuplets, naturally born before the ART, the reproductive technology era. They were identical, which is quite remarkable for quintuplets. I did notice recently there was a non-uplets born in Morocco, and remarkably, all are doing well. Quite extraordinary, just this year. That's not normally the case with large numbers. Once you get over quads, things start to get very difficult. So what do we know about multiple pregnancy? Just a few facts here to get a bit of a framework around it. In England and Wales, there were over 9,000 twin pregnancies, 137 triplet ones, and 6 quads or higher. The data, the general data doesn't provide for what those over quads were, but you could probably do a bit of research and find out that I think there might have been a quin or 2 in that year. And the interesting thing about how multiples work is that they've been pretty much in decline through the 50s all the way through to about 75. And then along comes a reproductive technology and the rate jumps up quickly. So it's 13.2 declining, declining mainly because of decreasing parity, women having less children, because more children a woman has, the greater the chance for multiple pregnancy that then follows. So decreasing parities in the decline, and then reproductive technology comes along and the number jumps up. But as it turns out, the number 15.3 in 2019 per 1,000 pregnancies is not a lot higher than it was back in the 50s. It's a bit higher. And so we see that there is decreasing parity is the reason for the decline. The increase, there are 3 factors: the high rate of embryo transfer in reproductive technology, ovulation induction drugs, and increasing maternal age. So those are the things that Louise Brown was born in 78. So pretty much from that point onwards, as reproductive technology takes off, the multiple pregnancy rate jumps. If we look in the US, we find that the rate of twinning's gone up in that time period by 50-odd% from 1980 through to, actually, I can't see how that, probably do that, there we go, by 50% over that 17-year period, but triplets and higher went up by 404%. So it's the real higher order ones which have really taken off. And so we here in this, see in this particular graph, if you look at the, I know it's very messy, but it's just showing the year along the bottom, and this is just for twins. If you look at the blues, Denmark, it's sort of a typical kind of curve, declining with increasing parity. Along comes reproductive technology, it really takes off, and then it's leveled out in more recent years. If you look at specifically at twins and triplets in the US, the triplet rate has turned over. That whole business about multiple embryo transfer was at least partly addressed, and so triplet births started to decline around 2000 when something like single embryo transfer became more common. So what are the risks with a multiple pregnancy? Because this is really the kind of rationale here is that there's risks with multiple pregnancy, and reduction improves the circumstances for the surviving children and for the mother. So for the child, most risk is a result of prematurity, and the more fetuses, the more risk. So perinatal mortality, which is, I think, after 24 weeks and up to 7 days after birth, is higher for twins than it is for singleton, those numbers 6.6 versus 4.1. But something very interesting happens if you compare premature twins with premature singletons, the reverse is true. So the rate for singletons that are premature is 3 times higher. That's most likely because twins are in hospital earlier and receiving much better care and more attention because they're likely to be premature, whereas a premature singleton comes out of the blue and you have to rush off to hospital, and that's when some of the problems occur. Cerebral palsy increases with the number of fetuses. So what's the incidence of MFPR, multifetal pregnancy reduction, and how has it changed with time? Well, it started in the late 80s, as I mentioned. It's very difficult to find out what the actual prevalence is, but one report, there were a couple of major studies, one of 1,000 consecutive cases at Mount Sinai Medical Center over a 13-year period, then another 1,000 for the next 7-year period. And that suggests roughly a doubling in the rate. But of course, this is only one center, but it's a major center in the US. Besides the actual numbers, which are kind of hard to get a handle on, what's actually changed? Well, earlier on, the kind of thinking was that when you get quins, sextuplets or higher, or quads and higher, the risks are right up there, and so they become very hard cases, if you like, the hard case. And so there were very few examples of twins being reduced to a singleton or triplets being reduced to 2 or 1. Those are much lesser in number. But now twins to singletons increased over that time period of those 2 sets of cases from 4 to 15.6%. So there's much more reduction down to 1 fetus. And if you talk about regardless of starting number, the desire to reduce down to a singleton has increased dramatically as well, and increasingly for quality of life reasons. So people who have triplets, rather than reducing down to 2, tend to be more reducing down to 1. And of course, most of these cases were reproductive technology within the context of RepTech. If you look quickly at England and Wales, you've got about 50 to 80 cases per year in the 2000s, and coming up to about 140. So about in the low 100s each year. I suspect that population-wise, you could probably get a rough idea of something like the States. This is even more the case, reduction to a singleton in England and Wales, between 60 and 76% of cases are reduced to a singleton. I'm just going to skip those two. So what kind of outcomes are we talking about when researchers study these MFPRs, multifetal pregnancy reductions? What is the main focus of interest? I should say up front that the research in this area is pretty poor, I reckon. It's not the kind of high quality research that should be coming out of the field. But there are 2 ways in which you can look at outcomes. One is to compare a multiple pregnancy reduced versus unreduced. For example, comparing triplets reduced to twins or a singleton compared with expectantly managed triplets. That's just triplets born naturally. So that seems to make logical sense. You compare the triplets as they are, left alone, versus the reduction. But you can also do it a slightly different way, and researchers will study pregnancies reduced to a specific number versus that specific number managed expectantly. For example, it's triplets reduced to twins versus twins managed expectantly. And the reason they do that is to try and see whether the reduction causes the same set of outcomes to happen as would happen for that reduced number. So in other words, if you're reducing triplets down to twins, is it as if they were just twins in the first place? Most of the research is in this first area, and I think it probably makes more sense to be looking at expectantly managed triplets, in other words, leaving them alone versus comparing with what you would do to them. So what are the outcomes measured? First is pregnancy loss, the risk of pregnancy loss. So this is one of the risks of the procedure, that you could lose all fetuses before 24 weeks. You then can look at morbidity and mortality of the infants. Prematurity and low birth weight, that's the key one that is the goal of the technique, is to limit prematurity. Maternal physical and psychological health, and the physical and psychological health of surviving children, about which there is zero research. So these are the 5 kind of areas that are subject to research. Let's look at pregnancy loss. So in other words, what's the risk of losing that whole pregnancy when you do MFPR? So for quads, the risk of losing the pregnancy actually decreased from 25%, that's what would normally happen with quads, versus after MFPR down to 12%. So there's what you might call an improvement in pregnancy loss. The opposite happens with triplets. It does depend on the type of triplet pregnancy. But if you reduce down to twins, then the risk of losing the whole pregnancy goes up from 5 to 7% or 9 to 13, depending on the type of triplet pregnancy. And if you reduce a triplet down to a singleton, it's even more risky, and you're more than doubling the risk of losing the whole pregnancy. Twins, the loss has increased to about over five-fold increase from 0.7% to 4% loss of the whole pregnancy. So this is the kind of risk side of the ledger. Mortality is also on the risk side. Both, there are a couple of ways, or several ways you can actually measure mortality. One is perinatal mortality after 24 weeks and within 7 days of birth, but the data is inconclusive. It's only inconclusive in as much as, is there an increase in mortality after MFPR or none? There's definitely not an improvement. So there's a greater risk of mortality, but it's not definitive. Infant mortality is defined as death within 28 days of a live birth. And again, that's inconclusive as well, but it's certainly not an improvement after MFPR. It's either no change or maybe an increase. The research is still inconclusive. There's another way of measuring about mortality, and that is, what is the risk of no surviving child after reduction? And I suppose in a way, this is kind of a collective of the risk of loss of the whole pregnancy, plus these different definitions of mortality. So it's almost like a take-home baby rate, or taking home a child at all. And after MFPR, that risk increases from 5% to 8 to 9 or up to 18, depending on whether it's reduction. This is for triplets, by the way, down to twins or a singleton. For twins, the risk increases quite dramatically. So it may well be that occasionally after MFPR, one twin, say you've got triplets and reduced down to twins, one of those twins may survive, the other may not. But if you look at those numbers of pregnancies where there's absolutely no child surviving, that's what this is talking about. And that's definitely increasing quite significantly after the procedure. Now I'm going to go through this really quickly because the data is fairly clear on this, that prematurity is improved. In other words, less premature infants after the procedure, MFPR. So from quads to twins, it's quite a dramatic. From triplets down to twins, again, quite large. Triplets down to a singleton, quite large. Twins to a singleton, again, with some studies being a bit unclear. So clearly prematurity, which is obviously a problem that leads to morbidity of various sorts, is improved after the procedure. Just very quickly though, there's something interesting that has been found in some studies, and that is that if you look at prematurity from 32 to 37 weeks, that's higher, this is for twins, higher for expectantly managed twins than it is when they're reduced to a singleton. So 42 is a big difference. So, but when you look at extreme prematurity, that's before 32 weeks, then it's reversed. And in fact, the procedure itself is actually worse. It's creating greater prematurity. So that is that the premature births associated with the most serious adverse outcomes were more prevalent after MFPR. And it's interesting, the authors say the outcomes for twins after 32 weeks are in any case favourable. I should have said up front, I'd forgotten to mention that in the 20-year period from the 80s through to the 2000s, the improvement in care of infants in a multiple pregnancy has dramatically improved. Care there's something like an 80% reduction in perinatal mortality of triplets over that time period because of advances in care. So multiple pregnancies are not as risky as they were in the past. So maternal health, physical, multiple pregnancies do carry an increased risk of this excessive vomiting and nausea, hypertension, hemorrhage, caesarean section, preeclampsia, and gestational diabetes. So they're all increased in multiple pregnancies. Unfortunately, the age is a confounder that has not been controlled for well in the studies. So it's not easy to get at the facts here, but it's probably fair to say generally that there are improvements for the mother after the procedure. So here's one particular study where triplets reduced to twins. There are improvements in hypertensive disorders, high blood pressure, the rate of C-section and gestational diabetes. If reducing twins to a singleton, there were no real differences in maternal health, but except possibly a slightly reduced incidence of preeclampsia. So to summarise that, in terms of physical health, there are some improvements. They're not dramatic. But I should also say that, as you can see, most of these studies are triplets down to twins or occasionally quads down. There's hardly any studies of higher order pregnancies where there may be quite a difference. It's just that there's so few and far between that they've never come up in reports of a controlled study of any sort. So the psychological health of the mother sort of falls into two categories. One really is the nature of the decision-making process, and that's clearly the studies that do this show it's deeply traumatic. And keeping in mind that most of these cases of multifetal pregnancy reduction are within reproductive technology, we're talking about pregnancies that are deeply desired. And so it's not surprising that it's a deeply traumatic experience. Some women described what they called a profound perinatal irony, that they had an overwhelming sense that they were so infertile, there was no way that they could have a problem with being hyperfertile. And when I read that, I thought, that's really odd, because that suggests that those women have not been told what is well known when they're being counselled prior to reproductive technology treatment, that the incidence of multiples is a risk. It's a clear risk with ART. And if some were shocked to discover that they had a multiple pregnancy, there's something lacking in the informed consent process. And this is the kind of alternate comment that comes up from time to time, where this particular person says, we created this child in such an artificial manner in a test tube, choosing an egg donor, having the embryo placed in me, and somehow making a decision about how many to carry seemed to be just another choice. The pregnancy was also consumerist to begin with, and this became yet another thing we could control. So for some, rather than being a deeply traumatic experience, it did seem like this was a natural extension of what they were experiencing in the context of ART anyway. Researchers that look a bit more closely at longer term, and there are very few of them in this area, you find these sorts of statements occasionally appearing. At the time you make the decision to reduce, parents don't know what the future will hold. Some of the families go on to experience a lot of grief. At every milestone for the child they decide to keep, there is this ghost in the room, this feeling that there should have been two of them. So there's this sort of something about the reduction of a multiple pregnancy which makes it different from abortion, it seems. And I'll just go on to explore that a little bit more later. Just further on psychological health, because there's such little research in this area, and there's so much in the context of abortion, elective abortion, one would have thought that since both are examples of fetal loss, that you'd expect something similar after MFPR in a woman's experience, because it's fetal loss and it's a highly wanted child. So, I mean, this is, as everyone knows, this is a huge and contested field, but you would certainly expect something. And what is less contested is that when we're talking about mental health after an abortion on the grounds of fetal anomaly, the evidence is quite a bit stronger that there's quite significant adverse mental health outcomes when an abortion is undertaken for those reasons. And then MFPR is sort of within that territory. As I mentioned earlier, there's been no research at all on surviving children, even though many of the publications early in the piece make this one of their concluding comments that we must do research on the surviving children with MFPR. But of course, it's a fraught area. So one wonders, you know, should or would children be told that their siblings, that they survived and a sibling was reduced? Interesting question in its own right. I couldn't find any research that showed what decisions couples had made in that regard. So why is it that there's been this mission creep, or whatever you want to call it, this change in the landscape, the hard cases at the start? It's not a sort of unexpected scenario. With many technological developments, there tends to exist some sort of mission creep when there's some key foundational principles that shift. So I think, you know, we could say there's culture of broad acceptance of abortion as a woman's right. That's a sort of a cultural context that needs a lot of qualification, which we won't go into now, but it may be one element. Another may be that given that we know that when surveys are conducted, there's a particular acceptance of abortion on the grounds of disability. So people will answer questions about abortion in quite nuanced ways. But sadly, one of the categories in which there seems to be a fairly high acceptance of freedom to carry an abortion is on the grounds of disability. I also think there's something else here, and just reading a lot of these papers, there's this sense that comes through that quite a few of the medical professionals involved seem to be so committed to an ideal of health that they regard a multiple pregnancy in its first instance as a disaster because there are risks, and then that everything should be done to kind of correct that. I wonder whether there's something deeper in the psychology too, that's been technology which has driven this rise in multiples, and that therefore the technologists are somewhat responsible for reversing that. Also, instrumentalizing human life in reproductive technology may make a utilitarian calculation seem somewhat more straightforward. That's an interesting one. I don't know quite what to think about that, but and of course, increasing maternal age. So there's certainly some evidence amongst the American research groups that there's an increasing number of older women coming into reproductive technology who have already had some children and want another, but are at that stage of life where they can't imagine having more than that. And so that this may be one of the reasons why the rate stays up fairly high. Yeah. Now, I just have a couple of words about what comes up sometimes in attempts to discuss the ethics of multifetal pregnancy reduction. And most people will be familiar with the lifeboat dilemma, that you've got this lifeboat and you've got all these people in there and it's sinking, so you have to turf a few out so that some can survive. It's kind of a poor analogy here, but it might I nearly said hold water, but it might be there might be something in it. Interestingly, the lifeboat dilemma is usually used when dealing with persons. So it's interesting that it comes up in this context where many of the practitioners do not consider fetuses to be persons. It's interesting also that a lot of people who, when asked about their experiences, use the language of sacrifice. So this Dr. Wu, he looked at the physician, he said one had to be sacrificed so the others could live, so the other two could live, right? So he's asking the question based on his assumption that the only way that his two could live is if one was actually sacrificed. So that's a lifeboat type decision. So people are seeing it as a lifeboat, some are at least. Precious little one, you're sacrificed again. So the language of sacrifice is used by people when they talk about this. And if you go onto some of the forums, and there are plenty of them, it pops up again and again. And people talk about sacrificing one to save others. It does make you wonder what's being said to them. Because if people are believing that the only choice they have is to sacrifice one so that others will live, they're being misled, because in fact, in reality, it's just to potentially improve the circumstances for the remaining ones, but at significant cost of mortality and perinatal loss and the risk of not taking as many children home. So, and of course, the loss of the whole pregnancy. So it does seem odd that people use that kind of language. And I just wonder, again, what's being said to them if they do contextualize it in that way, that it's a sacrifice to save the life of their brothers or sisters. There's another problem too, in that even if we talk about fetuses as pre-persons and the lifeboat dilemma takes a slightly different form, then it's also problematic because it's completely arbitrary. There's no reason why you would choose one fetus over another if you hadn't done some diagnostic thing. So I think that, to me, that seems to add some level of difficulty when there's a complete arbitrariness to how the people, the persons, or even pre-persons are dealt with. And I mentioned that just a moment ago. It's not really about saving lives, but improving outcomes, sometimes by a very small margin. So just to finish off with, I'm not sure how we're going to, I better finish here. Just a couple of quick comments about MFPR and abortion. So even though for those who describe themselves as pro-choice, there seems to be something particularly troubling about MFPR that distinguishes it from abortion. So this comes up in quite a bit of the popular literature where people are discussing this on forums and so on. They say they're totally pro-choice, but something really bothers them about this. And I find that intriguing. So there's something there. And there's a writer called Salatan who thinks that the reason that that's the case is that it exposes something. He says the main problem with reduction is that it breaches a wall at the center of pro-choice psychology. It exposes the equality, and this is the arbitrariness we're talking about, between the offspring we raise and the offspring we abort. It's all within the one pregnancy. So it sharpens things. So when we'll be familiar with this, that the language used for a wanted versus an unwanted pregnancy can be for the wanted, there's a baby or an unborn child, whereas for an unwanted, there's a fetus or an it. So MFPR destroys the distinction between wanted and unwanted, for both exist in a single pregnancy. So I think what it's getting at is related to that question of arbitrariness, that you might sort of expect someone to consider an abortion within the context of one particular pregnancy because of all of the circumstances that surround that one pregnancy. But here there's only one set of circumstances surrounding the pregnancy, one set of experiences, but multiple unborn children, one or more of whom are terminated. And so it makes it really sharpens the question of the difference, really described in this way by this same author, that the anguish of reduction, watching the fetus you spared become what its twin will never be, knowing that the only difference between them was your will. So it somehow sharpens the whole question. So I think I'm going to leave that there. and really happy to try to answer any questions. Sorry, I can't hear anything here.
Thank you very much, Greg, for that very interesting presentation. And would anyone like to kick off with a question or a comment?
Yeah, I can. Thanks, Greg. That was really fascinating. And I don't know, it seems to me that there's so little research done that I don't know how people are giving meaningful consent to these kind of procedures, because there are so many unknown consequences for the surviving child and for the mother and that kind of thing. I don't know. I find that quite disturbing, I guess. And like you said, I don't know how you could investigate the psychological effects on a child without informing them of it, or I don't know. That's just whole up in the air. But you know, anyone who puts themselves in the position of discovering that by completely arbitrary choice of your parents, you're the survivor, I just have no idea how I would react to something like that. It seems horrific to me. Just allied with that lack of consent, I would have thought IVF clinics themselves would be strongly recommending against this, given that it seems to increase quite a few of the risks. Do you know anything about that? Is it something they are advocating, or they're trying to prevent?
I haven't seen anything suggesting that they're doing either. The practitioners themselves seem to, the ones who are carrying out these procedures, tend to sit somewhat outside the reproductive technology industry. But one of the American ones who really kicked all of this off in the States, he uses the language like this. He says, MFPR is an integral fail-safe for reproductive technology. So he's saying that you know, rep tech, if you're going to have rep tech, you're going to have this problem, and you're going to have this problem, you've got to have a way of fixing it, and we're the ones who can fix it for you. But as far as the clinics go, I haven't seen anything. If anything, there's a reluctance to even talk about it because it's such difficult territory. It doesn't even seem to come up. You can go to various of the key sites and talk about selective reduction, and you dig a bit deeper, you find some explanations of what it is, but certainly not in terms of any evidence base. That's left to the actual specialists themselves. Anecdotally, I've read that people are being, some practitioners are suggesting that this should be mentioned to people up front, that selective reduction is the type of thing that's a possibility if you get a multiple pregnancy, so don't worry. The business of balancing those risks is intriguing to me, because it's almost like, how do you describe it? It's almost as if there's an arbitrary preference and desire, which is really at the core. In other words, don't want to have more children, certainly don't want to have any unhealthy ones. So a preparation to take the risk of the increased mortality, the increased total pregnancy loss, because there are almost other reasons, but those are the ones put up as the reasons why. So, you know, you don't want any prematurity because it's related to various risks. Yes, there's a risk you lose the whole pregnancy, but you don't want any prematurity. You mustn't have prematurity. You must do the best for your surviving children. So you really should do this. That's my suspicion of what comes through in some of the practitioners.
And I guess IVF clinics are still implanting multiple embryos instead of the exact number that people want. So,
yeah. So what's happened is in the UK, for example, you'll find that is it the HFEA? I think it might be HFEA have made a very big effort to reduce the incidence of multiples in rep tech, and they've had some success. So the figures that come to mind were that the multiple pregnancy rate was 24% and in England and Wales, and it's come down to about 8% within the industry. So that's just those pregnancies within the industry. That is still 5 times the spontaneous rate of multiples. So it's still very high. And part of the reason is that you can reduce the number of embryos transferred all the way down to only ever transferring 1. But if you're using ovulation-inducing drugs and you've got older women, those other reasons will outstrip the reductions you'll get from transferring less embryos. Does that make sense? So you're putting in less embryos, less multiple pregnancies, but unfortunately embryos, the embryo number is about 1/3 of the incidence of multiples in ART. Increasing maternal age and ovulation-inducing drugs are the other 2/3.
Okay. So
embryo reduction is only going to give you some reduction in multiple pregnancy.
Interesting. Thank you.
Yeah, so it's still, multiple pregnancy is still quite high in ART. In the States, it's about 8 to 10-fold higher than the spontaneous rate. The other thing, in the UK, of course, what's his name? Lord Winston. He really got stuck into the clinics a few years back, and he said they're greedy and corrupt, and that they would really be more interested in transferring more embryos or using more ovulation-inducing drugs so that they could get the success rates, and the casualty was multiple pregnancies. So clinics compete. They compete with one another to get high pregnancy rates, and you get high pregnancy rates if you push things a bit, but you get multiples too.
Any more comments and questions?
Just a quick question to understand better. So when it comes to fetal reductions, I mean, those fetal reductions don't have to comply with the law on abortion, are not treated, are those reductions treated as abortions in terms of law?
That's a sort of a technical legal question I'm not really sure of, but okay. I had done a little bit of reading early on, and I think that's the case. In England and Wales, when I looked for those numbers, you know, I had numbers about roughly 100.
Yeah, in fact, this is why I was asking, because you have all numbers.
Yeah, so those numbers coming from your Department of Health, I think, puts them out. Anyway, that major abortion report each year. So in there, I think it's 80-something% of the selective reductions are on the ground E, which is ground E's disability. Is that right? I think ground E is disability. But then if you go to RCOG, the Royal College of Obstetricians and Gynecologists, they say that specialists rely on ground C for all of these cases. So that discrepancy I haven't been able to resolve. I don't know why it's there. Ground C, which is the main one, which is the physical or psychological health of the mother, doesn't seem to fit this at all. I mean, at a stretch, you can argue that this is about reducing the risk of disability, but what's the terminology in the UK legislation? Something like substantial risk and...
Yes, but it's quite a big umbrella.
Big umbrella, substantial and something else. There's 2 words, I've forgotten what they are. And they are quite loose. So legally, under grounds, when there's that mismatch, but they're actually recorded under ground E as far as the report goes, but the RCOG says that most are ground C. That seems
I mean, maybe because, I mean, if you do an abortion under ground E, you can carry out this abortion up to the end of the pregnancy. So in fact, I mean, usually at what stage of the pregnancy are done those reduction? I guess not early stage.
Usually around 12. There's one paper I recall 7 to 8 weeks.
Okay, that's early.
The outcomes were very poor, but usually around the 12 weeks and sometimes up to 16. So pretty early on. Yeah. They've refined their techniques, and I, you know, it'll be interesting. I wouldn't be surprised if someone does the research over the next 10 or 20 years. The practitioners will get better at their craft. They'll get much better at their craft. And then, you know, the kind of arguments you might want to use about perinatal loss or increased risk of total pregnancy loss and lower take-home baby rate and all those sorts of things, if they refine their techniques so well that it's always a plus side and always an improvement doing this technique, then we're pushed back on the moral argument straight away. All the time we're pushed back to the moral arguments. We may as well take it up front. But nevertheless, the sort of utilitarian calculation in a way works for people who think, or can work for people who think that way. That there are significant risks with this procedure, but we just have to acknowledge that those risks might decline over time as the practitioners get better and better at doing what they do.
Thank you.
One thing that occurred to me listening to what you were saying about the arbitrariness for the mother, because here is a much wanted pregnancy and there's nothing that distinguishes one child from another, and yet one goes to term and the other is terminated. You do get something a bit like that with frozen embryos. I mean, I have heard descriptions by parents of, I mean, many IVF parents with frozen embryos are reluctant to actually say, please destroy my embryos, you know, even if they constantly get letters from the clinic or whatever, but if they don't like to say that, they might try and avoid the problem and not look at it at all, but they don't feel completely happy with that. And one reason seems to be that they can see one of their children at least that have grown up, and they think, well, you know, the scientists could have taken a different straw and it could be a different child who's growing up now. The complete arbitrariness of this, you know, this embryo was in the freezer and the scientist happened to take this straw and this child was born, but that could easily have been another embryo who's still in the freezer. And you can see your child, your born child growing up, and it makes it quite easy to see, well, that's the kind of life that the other embryo could have had, and could still have, in fact, you know, if you haven't yet, you know, if you're still able to carry the pregnancy and you haven't yet made the decision. And so, yeah, it occurs to me that some of that is there, and even in the case of natural pregnancy followed by abortion, you do hear descriptions of people saying that they feel sad when their born child has a birthday.
Yes, I heard that.
Yeah, they feel you know, someone's missing.
Yeah.
So there are some parallels. I mean, it's very stark with pregnancy reduction, but there are some parallels, I think, for other situations.
Yeah, I wonder. Back to what Bruce said too about what it would be like for a child, sort of thinking, "Gee, I just got through by the skin of my teeth, really, didn't I?" If it was just, could have been me, could have been the other.
Yes.
It's that kind of feeling. It just brings it all very, very, very close, I suppose. It's a nearness of it. Yeah.
Yes, you can imagine some kind of survivor guilt going on, perhaps. But I do remember, you know, outside any context of abortion or fetal reduction, sometimes you do hear stories of surviving twins who didn't even know they were twins. Having some kind of impression there was someone missing. So some very, very early memory, you know, and I remember one story, the person said, I just always feel there should be someone else there. And the mother goes, white, because, you know, one baby was just born dead, well, it was stillborn. And she said, I was never going to tell you that. So yes, I mean, there's all sorts of other things that could come into, you know, perceptions. But even if it's not an early memory, you could intuit from the way your parents treat you, perhaps, that there's someone behind you that who isn't there, or that your parents are sort of searching for someone who's not there. So and that could give you the idea that something had happened, whether a natural stillbirth or whether pregnancy reduction.
Yeah, I've often wondered about whether the subtleties of parental behaviour are picked up. It's the sort of the odd glance or the odd set of circumstances, the way a question was answered or something said, or which creates that odd sense of in the child that there's something there. There's something I'm not being told. There's something, I don't know what it is, but there's something.
Yeah.
I was wondering, you mentioned that there is very little research on the psychological effects on the child, and we probably see why, because of the problematic nature of telling such child that they had a brother or sister, and that brother or sister was, well, killed so that they could survive better. But what Helen was saying was making me think, obviously there would be certain biases, and it wouldn't, the results of such research probably wouldn't be so necessarily so good. But I was wondering if there is a little bit of a space there to look at those other cases, which is they're a little bit less problematic. For example, children who've lost their twin naturally, or
separated.
And see how they are psychologically, how the psychological development has been, and making the right sort of specifying the right differences. We could see that, looking at them, we could either argue that it could be worse for those who are a result of a reduction, or better. I don't know. Would that be something that someone could do?
Yeah, look, I wouldn't be surprised if there is some research that you've described on twins and other multiples. I wouldn't be surprised if that exists, or it reminds me a little bit of some of the adoption research. So yeah, you'd have to, like you said, think of a parallel set of circumstances and go hunting in the literature. And I mean, there's so much research on twin psychology. I'm not a psychologist, but I know there's a lot done on twins. And so there may well be something there. It intrigues me with, it just popped into my head when, you know, when this all was taking off, a lot of the papers are talking about the need to research the children, and that they'll just go ahead and do that research and we'll find out what the psychological impact of this is on children and so on. But I wonder, you know, it had a tiny parallel to the mitochondrial donation stuff, which is pretty hot topic at the moment, because in that context, again, even the legislation in the UK, I believe, says that the children need to be studied. The children born of mitochondrial donation will need to be studied. But you can't make that kind of declaration, because it's entirely up to the parents and those children as to whether they want anything to do with it at all, anything to do with the research. And certainly if there are any traumas, whether it's in that context or in this one, whether there are any traumas, we know from the research on psychology of abortion, psychological impact of abortion on women, that trauma is the very thing that will drive women away from participation in research. They're not going to, the most traumatized ones will not want to participate in the research, and that skews the research. So any context of trauma becomes a really difficult, or potential trauma becomes a really difficult one to study. But yeah, no, I totally agree. I think there probably are some parallels that go hunting and find out if there are similarities there. Yeah. just while there's thinking time, the thing that's intrigued me with this, which I haven't been able to find much information about really, is whether there's a shift from MFPR in the context of reproductive technology into the spontaneous multiples, territory of spontaneous multiples. That's something I can't really find so far. The only slight bit I found was the 2%. In that, remember, there were thousands cases and then another 1,000 cases. And in those 1,000 cases in the US, 2% of those were from spontaneous multiples. But really, if you get down to it, why would there be any, if all of the justification for doing this relates to the risk of multiples, that risk of multiples is just as likely to happen whether they're spontaneous or born in ART. So why wouldn't it gradually shift over into the territory of spontaneous multiples as well? It's already starting to shift into the territory of twins, down into triplets and down into twins, and sometimes for personal or socioeconomic reasons. So why wouldn't it, there's this kind of sense in the literature that, oh, we just need ART to clean up its act. If ART cleans up its act, problem over. But I don't think that's the case. The problem is you've set up the kind of circumstances, the language and the counsel given to women with multiple pregnancies, full stop, whether they're in ART or spontaneous multiples. The language is multiple pregnancies are a problem and we can fix them. So it doesn't have to be constrained by ART. It started in that context, but it has the potential to take a life of its own outside of it. I think that'd be very disturbing, but already with that 2% figure, it's starting to, and that was back in the mid-2000s. So I just haven't seen any research in the last 10 or 15 years that gives numbers or characteristics of whether they were reductions within ART or outside of ART. I suspect they're mostly done within ART still, but I'd be interested to know if it's crept out. These things get a life of their own.
Sorry, Greg, so your question would be, will you find interesting, because I am a midwife and I've known that in the hospital where I used to work, there's actually a dedicated multiple pregnancy team. And as much as they're very, very good at looking after twins, because that's their specialty, I know for a fact that they do offer a fetal reduction as one of the things that they do, which is very sad. But so you say there is definitely, and these are not necessarily only artificially conceived children, they're also naturally conceived twins or triplets or multiples. So that is definitely happening. You're more looking into what is the rate of that happening and how much is that.
That's right. Yeah, I couldn't find anything about whether that rate, what that rate is now, and whether it's shifted over time. But my sort of inclination is that I wouldn't be surprised if it would, because it's MFPR has now become a kind of a standard part of what could happen with multiples. So however they're conceived. Like you say, if selective reductions are a part of the normal language in that setting that you're talking about, then yeah, you'd expect that possibly it would happen with spontaneous multiples at a greater rate than it is now. I just think that would be an example of something just moving from one context in which it was argued to be essential, integral fail-safe for ART, into something else, into more broad application. I think it would be very sad if that was the case, but it may be that it's increasing in proportion. Don't know.
This does seem like one of the areas like abortion for fetal anomaly, where you get the same language. I mean, it's a baby, not a fetus, and there's very open expression of loss and so on. And But I was struck by that quote that you had from the New York Times of the woman who says, we wouldn't have done this had this been a naturally conceived child. But the whole process was so, production-like and so forth. I mean, that very couple said they were going to tell no one about the reduction, and no one would presumably include the child above all, you might think, but not even the close friends, not even family.
Yeah. When you read some of these forums, you get that theme coming through that people are very reticent to say anything because they talk about the judgment of other people or the negative stuff they get back from other people. How could you do this sort of comment? So yeah, people will be very reticent, I think. Very reticent to tell anyone about it. There was one bit of research where there was a comparison between the experiences of women still pregnant who had the reduction versus those who hadn't, and the ones who had the reduction were deeply troubled by it in an ongoing way through the rest of the pregnancy, but none of the others who'd chosen against their reduction, none of them experienced that. They were very happy with the decision. So the ones that had made it were deeply troubled by it and stayed troubled by it. They eventually felt that they'd made the right decision, but they found it tough going. So yeah. So that may be, people sense that they've done something that was incredibly difficult, and they wondered whether they really should have. I don't know.
Yeah. Any more questions or comments?
I guess sorry, did you want to speak, Julie?
You go ahead and I'll ask later.
It's just interesting, this kind of thing. We saw it with ART and we see it with MFPR, these procedures that inherently have a lot of potential ethical problems. People just go ahead and do them, and well, maybe we should do some research sometime.
That could be me dropping out. Hey, Kathy.
I'll just wait a minute for Greg.
I mean, while we're waiting, maybe Julie, you'd like to make your comment, or?
Well, yeah, it was I just want a little bit of a clarification on that comment that he presented on the slide, which was about a woman saying that she felt so infertile that it was, and then all of a sudden she became incredibly fertile. I didn't quite understand her comment and what that meant. I just want a little bit of clarification on that. If anyone knows.
I took him to be saying that if you're having fertility treatment, you assume you're not a very fertile person.
Yes.
And so you are not anticipating that you're going to be pregnant, let alone with triplets or but yes, you think of yourself as having one child at most if you're lucky, rather than.
That shows also how little they're cancelled by the infertility clinic, because it's quite well known. It's quite a high rate of multiple pregnancy when that comes to with IVF. So it's interesting. Is it what the comment was then?
Well, I think so. I think it's and I suppose even if you've been counselled to some extent by the ART doctor, you may think, well, it's not going to happen to me.
Yeah.
I've been trying to have a child for 7 years or whatever. I am not a very fertile person.
And does that lead them to go for reduction a bit more or less? That wasn't my. Didn't quite understand the point.
Well, I think the point was that you're more surprised when you find yourself with multiple pregnancy.
Greg, can I continue with just my general comment?
Yep.
Okay. It's just, I don't know, a lot of these things are kind of chicken and egg when it comes to research. They seem potentially unethical to do, but you have to do them to get the research to show that the effects are bad, like ART possibly, or whatever it is. So I don't know, it just seems very strange to me that we end up doing all these kind of procedures like fetal reduction and ART, knowing that they're potentially really severe problems with them, especially ART could have, I mean, who knows what could have resulted from that long term. But we just go ahead and do them anyway and sort of worry about the consequences later.
Yeah.
Anyway, just a general comment.
Yeah, I guess that's sort of a hubris thing, isn't it?
Yeah, I guess it is.
That's really what struck me about the mitochondrial donation stuff too. That was an extraordinary example of massive potential consequences, and just thrown all caution to the wind. Quite amazing. But I suppose philosophers would be better at this, but the rise of utilitarian thinking, and there's the greater prevalence of utilitarian thinking on people's part, makes it easier to do this sort of thing. Because was it McIntyre who said utilitarianism is a smokescreen for arbitrary preference and desire? So that kind of arbitrary preference and desire, and I think maybe it might sound a little unfair because you've got practitioners saying things to women which are true about the risks of multiple pregnancy, but at the end of the day, if you don't hold fast to something of intrinsic value, then you're more easily swayed by those sorts of calculations, and at the same time you can fall easier for the, well, I really want to do this for whatever reasons, and as it's increasingly for social reasons.
Yeah, I mean, I expect with like ART, perhaps the thought was that if we notice anything as the fetus is developing, then we can abort and try again. Perhaps that was the reasoning behind it. I don't know.
No, I'm not sure. I know that with the mitochondrial donation, that's a bit of a tread carefully type thing there, with the same sort of thinking. Or just watch very carefully. The trouble is that once you've got a child born of mitochondrial donation, then what are you going to do? You just have to watch and see.
I mean, do you deliberately plan to abort after 7 months and do experiments confirming normal development to that point? I mean, that would be unsurprising, I guess, in today's world, but maybe that's where that kind of thing is headed.
Don't know.
Anyway, I'll leave that one there.
Yeah.
Any final questions or comments? Can I just thank you so much, Greg, for your excellent presentation, which is very, very thought-provoking. And I believe it's coming out a bit later in Issues in Law and Medicine, is that right?
That's right. I'm just waiting for some reviewer feedback, but they've said they're likely to do it in the July one, must be the summer next year. Yep.
We look forward to that, because it's an extremely I've had the pleasure of seeing the paper, and it's a very good account of the whole issue. But yes, well, thank you so much for your presentation, and thank you everyone for coming. And yes, this is the last session.
Last one for the year. Merry Christmas, everybody.
Yes, indeed.
Merry Christmas.
Hope you all have a great break.
Yes, well, you too. And yes, we look forward to great things in 2022.
Thanks, Helen.
Thanks
Thanks, everybody.
Thanks,
everyone.
everyone.
Bye. Bye. Bye.